Line. All right. So we're going to talk about, so we did valves last week, but it was pretty much just the mitral valve. So this week we're just going to talk about the aortic valve. So we'll go over the quick anatomy of the aortic valve, talk about aortic stenosis, aortic regurg, how to quantify those, and then the aorta, which we actually won't get to because I realized when I was at slide 88, I should probably stop. So can you guys see my mouse when I move it? Hopefully you can.
Yes.
No, you can. I'm looking at the same thing as you.
I'm sorry.
So this is the aortic valve anatomy, just like the mitral valve had an apparatus, so does the aortic valve. It consists of the LVOT here. These are your valve cusps. Remember in this view, you pretty much know this is the right cusp, but you're never quite sure if this is the left or non-coronary cusp because you're not always sure where you're slicing through. Then you've got the sinuses here, and then the STJ junction, which is the sinotubular junction, leading to the ascending aorta. The sinuses are important, and then it's important that it has this morphology. They just help absorb stress during diastole, and then also the leaflets can open without smacking into the aorta. So the aortic valve is tri-leaflet like we know, and I just kind of mentioned there's three cusps. So there's the right, the left, and the non-coronary. They should all open equally. So when they're wide open, you should get kind of this, you have to think, imagine a little bit, but like an equilateral triangle. And how they are. So this, remember, is going to be your mid-esophageal aortic valve short axis view, usually around 30, anywhere to 60. So your left coronary cusp, they're named obviously based on the coronaries, but they also kind of are in the same position as other anatomy. So if this is your left atrium, this is your left coronary cusp, and you can almost, I wonder if this is the coronary kind of starting to come off here. Sometimes you can see it. If you remember in this view, down here is your RA and your RV. So that's how you can kind of orient yourself to the right coronary cusp. The right coronary usually comes off right here somewhere. And then this is your intraatrial septum, left atrium, right atrium, septum. And that's usually in line with your non-coronary cusp. So that's how you can kind of. All right, we're back recording. And that's just so you can get some measurements through the valve. So that's the utility of this view. This view can also be useful if you've had multiple valve replacements because you're not trying to shine your beam through them. All right, so we'll start with aortic stenosis. So the most common cause of aortic stenosis is usually calcification. So just old age, degeneration, that kind of stuff. And then the second most common is due to congenital abnormalities, like a bicuspid aortic valve. Bicuspids usually account for about 50% of aortic valve replacements in the US and Europe. And basically, as you get distorted flow through the valve, that's when you get degenerative changes. And anytime there's degenerative changes, that's what calcium kind of glops onto and causes further degenerative changes. And then if you have a bicuspid aortic valve, a lot of those patients end up getting dilation of the root and the ascending aorta, whether that's just due to like collagen issues that lead you to have a bicuspid or whether it's due to flow issues. The jury's still out a little bit. But whenever you see a bicuspid valve, you always want to investigate the aorta a little bit more just to see if they have something going on with that. So here's the different kind of etiologies of aortic stenosis that we talked about. So this is your normal. You can kind of imagine if these were on echo here, this is probably more for a surface echo with these coronaries here than anything else, but that's okay. So when you have rheumatic disease, it's pretty much just affecting the tips of the leaflet. So the tips are very calcified in rheumatic disease. And then for calciphy, you can see the whole cusp is basically just full of calcium and degenerative. And then with bicuspid, what you look for is you can see even with rheumatic, and calcific, it still opens up. All the leaflets open up, so you get some sort of triangle shape. When you're looking for a bicuspid, this is kind of known as the fish mouth opening. And that clues you in that there is likely a bicuspid leaflet or a bicuspid valve. And usually the most common fusion of the raphe here is the right and the left. All right, so we're gonna look at some video clips. All right, here's one. So anyone, does it look normal, abnormal? And then what is the arrow pointing to?
Normal.
Okay, I'd say normal, right? It looks like it's opening all the way. Yep, correct.
Right.
Yes, the right coronary cusp. So you can see, so this was kind of the RV inflow out, or the RV is down here, so that's your right. Remember how I said sometimes you can see your left coronary coming off? That's probably what you're seeing right here, that little black dot. That is your coronary. It's always really hard to see the right one, but usually you can catch the left one, and that's what that is. All right, so yep, normal right coronary cusp. All right, what about this one? Abnormal, good. All right. What kind of disease process do you think this one is?
I'm kind of torn between rheumatic versus like a calcific. It's got like obviously sort of the edges look very abnormal, which leads me to think we're rheumatic, but there is kind of shakiness throughout the whole.
Kind of throughout here and stuff
Yeah.
like that, yeah.
Maybe I think probably more calcific.
Calcific. Calcific it is. And I stole, oh, by the way, I stole these from the aortic valve quiz on University of Utah. So if you ever, there's more there. I didn't steal them all, I promise. So if you ever want to review, that's a good site to review. Okay. What about this one? And again, we're not doing anything quantificated. This is just eyeball test. What do we think? Normal? All right. Yeah, normal. All right, so now we're, all right. Here's another one. Okay, so fish mouth like, bicuspid. All right, do we think the valve is normal or abnormal? I mean, we know it's bicuspid, but that doesn't always necessarily mean it's
Looks normal.
it's pathologic. This is all you get. This is all you get, right? If you had to guess.
I mean, it doesn't look like super calcified or anything.
Nope.
I'd say normal.
Do you think it's opening well enough?
I mean,
Looks like there's some restrictive opening.
Yeah, so there's probably a little bit of, so it's bicuspid, and I bet if you put color on it, I bet you'd see some turbulence for stenosis. For bonus points, what's this down here? That is your pulmonic. So this is your right atrial, this is your right atrium. Your RV is kind of, you can't really see it too well, which makes sense because usually you can see your RV inflow outflow closer at 60. And then you're flowing here. This is your RVOT and your pulmonic going to your PA. All right, here's another one. What do we think? Normal, abnormal. And then
restrictive opening.
all right, so I think people are probably getting caught because this leaflet up here kind of looks like it's flying, doesn't it?
Yes.
So that's probably not normal necessarily, but do we think the valve's opening enough? Or do we think there's like significant stenosis? Just with your eyeball.
It looks like it's opening enough.
Yeah,
Not
I think
like
it's opening enough. I would say no significant AS on this, right? It's opening enough. Definitely something little odd, but nothing that it's like this person has critical AS.
What is that level of weight you think?
I don't know. I only have these one views. You need more views. All right. All right, what cusp are we looking at?
Left coronary.
Left, correct. So remember, you can kind of see that, you can actually, behind this arrow, you can see that left coronary right back there. And remember, this is your left atrium. All right. What do we think about this one?
This looks dramatic.
This looks rheumatic. So this one's rheumatic, and you can see kind of that rattiness all around the leaflet tips here. All right. What about this one? So this is actually a TTE image. What do we think? Let me see if I can pause it because it's going kind of fast. What do we think? Ooh, right there is maybe a good cut. So this is it closed. Any thoughts?
That's hard to say, because you might saw that pain there if you sleep with it.
This is actually a quadcuspid aortic valve. So not the most common, but you can have unicuspid and you can have quadcuspid. I think Pagel has a video of a pentacuspid, so a 5 leaflet valve.
Yeah, he just published it.
There we go. Is that you, Dustin?
Yes, it is.
Oh, nice.
Hi, buddy.
Hey.
All right. We're getting almost to the done of these clips, I promise. What do we think here? And anybody feel free to chime in if I say something incorrectly or you want to add to it. What was it?
AB normal.
Okay, maybe a little abnormal. And it's hard, right? We're not putting color on anything. We're just looking at the valves. Just to get our eyeballs used to seeing normal, abnormal. And what kind of pathology do you think this is?
Rheumatic.
Rheumatic, yep. So remember how we said it kind of affects the leaflet tips? That's what we're seeing right here. These
So would
thickened
you think
leaflet
more
tips.
Of the annulus affected if it was calcific?
We can kind of go onto the cusps more than just the tips. All right, and I think this is the last one. What leaflet is this, or a cusp is this? Only one we haven't mentioned yet.
Non-coronary.
On coronary. All right. So that was obviously us just using our eyeballs to see if something looked normal or abnormal. Obviously, if you see something abnormal, you're going to want to interrogate it more. And these are the different quantification methods to do, or the guidelines say to help quantify aortic stenosis. So there's level 1 and level 2. Level 1 are things that should be done on anyone who you suspect has AS. And then level 2 are reasonable to obtain when you need a little extra info. So we'll go through these all to see what they mean. So the good news is you collect all of them in the deep transgastric long axis view. So the first one is your aortic stenosis jet velocity. So if you remember, you can line your beam up along the aortic valve here, and then you get measurements like velocity, for example. So remember, continuous wave Doppler is basically, it's measuring the velocities along this entire line. So it's not measuring from a specific point because that's pulse wave. So because it's continuously sampling, you can measure really high velocities. And if you had to guess, if you had a really tight valve, do you think you're going to have really high velocities or really low velocities? High velocities, right? It's like when you put your thumb on a garden hose. The smaller the orifice, the higher the velocities are going to be. So you're measuring how fast blood is traveling through that aortic valve. And like we just said, increased velocity is proportional to stenosis severity. Now you have to, in order to get accurate velocities, you have to make sure that you're lined up nice and parallel with the valve. If you're not lined up parallel, if you remember from last week, will your velocities be an overestimate or an underestimate if you're not lined up correctly? Underestimate, yep. All right. And here are the cutoffs. So basically anything over 4 meters per second is considered severe. And then anything 3 to 4 is moderate, and you can see the table here. And remember, because it's continuous, this is, you're going to get that shaded in that's shaded in, it's not a triangle, but shape. So basically, this is all shaded in, and your peak velocity is just going to be the very tip of it. So this one would be about 4. So yep, severe. Now you're going to use that exact same tracing to find your transvalvular gradient. So that's just the pressure gradient across the valve. Just like with velocity, if the pressure gradient goes up, your severity is going to go up. You do have to remember that this is going to be flow dependent. So if your LV is not pumping very well, you might not have high gradients. We'll get to that a little bit later. And basically the gradient is calculated from the velocity using Bernoulli's equation. But you don't have to worry about that because as long as you trace it, the computers will give you a gradient, a mean gradient. So basically, instead of just measuring the peak velocity, you take your cursor and you go and you trace it, and the computer will spit out a gradient. It usually tells you a peak and a mean. And similar, which is really nice, is that 4 is severe and 40 is severe. So they both have a 4 in them, which that's at least nice. It kind of doesn't work out as nicely down here, but at least for the severe category, that's easier to remember. So you get your jet tracing, you get a velocity from it, you get a mean gradient, and those are 2 of the 3 things already that you use to calculate AS severity. All right, so a question. I think this is a video clip. Yes. All right. So which of the following should be used to obtain the peak velocity and a mean pressure gradient of the aortic valve? Hey. Yep. If you use the pink line, what valve would you actually be interrogating? If you remember correctly. So this is your aortic valve here. This is your LV. What valve is this? Mitral. Yep. So that's alignment of the mitral valve.
Question.
Yes.
I don't know if you can, but when you're grading this,
Mhm.
let's say your gradient is moderate, but your peak velocity is severe. You just take the worst of the 2 and
So it's a little bit of a, usually if you have discordant measurements, well, one, you can get a third one as a tiebreaker. And then also you'll be able to put color on stuff and you'll be able to kind of just see with your eyeball. But yeah, sometimes you do get discordant values and sometimes you just cop out and you say moderate to severe.
This might be a weird question, but.
Yeah.
So if you're doing continuous Doppler.
Yep.
And will any tissue in the heart ever be moving faster than the blood flow? Like do you have to worry about actually hitting the valve tissue itself and being like, wow,
No.
look how fast that's going?
Nope.
No, okay.
Nope. And all you have to do is worry about sometimes on this is usually it's your valve, that's the stenotic thing. But if you do have like a subaortic membrane, if you do have stuff like that, that could be where your high stenosis is coming from. Because remember, just when you're continuous wave, you're not pinpointing any specific point. So, but that's why you kind of interrogate it 2D. Beforehand.
I would add to your point is in the operating room, if we see something that was described as less severe that was sold, we assume it was worse.
Mhm.
Because under anesthesia, it's never going to be that bad.
different conditions and when the
Correct.
fast is taken. Okay.
Mhm.
So if somebody was sold as severe MR and you're doing an operation for MR and you only see moderate, that shouldn't change the operation.
Okay.
However, if you see now moderate to severe AI, and that was not described at all before, that might be significant.
All right. How bad is the stenosis? So here's your values that the computer spits out for you. Moderate. See, this is much easier than MR, isn't it?
Yes.
All right. How about this one? Severe. And again, so here's your velocity. And just note the units, right? Because this chart's in meters per second, but a lot of machines will give you stuff in centimeters per second. So that's 4.6 meters. And then your pressure obviously is, mean right here, 58.
example, because your mean is 3.6.
What was that?
Just,
But we don't look at velocity mean, we look at peak velocity
right,
and mean pressure.
Right.
So the computer gives you more information than you need. All right, so those two are easy. Now we're going to do the third one, which is basically calculating the valve area. And this is where math comes into play. So this one will take our time a little bit more. Again, the computer actually will calculate this all for you, but I think it's useful to know how to calculate it yourself. So when you're calculating valve area, you're basically using the continuity equation, or the assumption that the stroke volume that goes through the LVOT equals the stroke volume that goes through the aortic valve. So basically whatever goes, the volume of blood through the LVOT has to match the volume of blood that goes through the aortic valve, right? There's nowhere else for it to escape. So this is during a beat. So if you can measure the stroke volume here, and you can have one value of this cylinder, you'll be able to figure out the area and solve for the area here. There are a couple things you have to measure for this, and anytime you have to measure multiple things, there's always a risk for more error than if you're just measuring one thing, so keep that in mind. And then some of those values even get squared, so there is always a potential for measurement errors. So we'll look at the math of this. So remember down here, this is your volume of a cylinder. So basically, the volume of this shape is our stroke volume. So we know the stroke volume going through the LVOT has to equal the stroke volume going through the aortic valve. Well, so that's another way to say that is using this equation for volume. So so pi r squared h, or basically, if you know the area of this circle, you can multiply it by the height, and that'll get you the volume. Does that make sense? The area of this circle, the volume, or the height. So remember, so this is going to be your area of the LVOT. So basically, assuming your LVOT is circular, which, you know, that is an assumption. And then your VTI. So if you remember your VTI, that's the distance a red blood cell travels during one beat. And you get that from anytime you trace one of these curves. So like, for example, this aortic VTI is right here. And that would be the distance, right, centimeters, that a red blood cell travels in one beat through the aortic valve. All right, so we know area of the circle times height. Okay, we can take that even further. So we know area of a circle is pi r squared. And we can actually measure the radius of the LVOT. And if you rearrange things, you get this big equation. And it looks a lot scarier than it is, I promise. We'll go through an example next. But basically what you do is you can complete the chart. And as you probably remember, any valve area less than 1 is considered severe. You can also index it for BSA if you wanted to. So body surface area. Okay, so let's go through an example of this. So let's say what we're measuring in each picture. So this is zoomed up right here. What do you think this distance is measuring here?
Diameter of your LVOT.
Diameter of your LVOT.
Does it matter what view you measure that in?
So typically you measure in the long axis view. And remember, we're using the equation for area of a circle, which is pi r squared. So we're going to actually take our diameter and make it a radius by halving it in 2. Okay. Now, you'll notice that this isn't shaded in. So this is using pulsed wave Doppler, which is this little icon right here, that little double hash mark. That's the area we're measuring at. So it looks like in this picture, this is right below the valve. So what specific area are we measuring in this picture? So your VTI of your LVOT. So yep, 32.6. And now this is continuous wave. So we know what we're getting here. All this shaded in is going to be at measured along the line, but we know that all these high velocities are going to be from the aortic valve, because we assume that that's the area of basically the the highest flow or the highest velocity of flow. So using continuous wave Doppler, what VTI do we have here? So this was the LVOT, this one is the aortic valve. Yep, so we have, and these are the components you need. So basically you need these three measurements to make a calculation. So if we're gonna figure out our valve area, we know that stroke volume of the LVOT equals stroke volume of the aortic valve. So we have our area of the LVOT times VTI. We're gonna solve for our area of the aortic valve, and then with that gets multiplied by the aortic VTI.
Let me ask a question.
Yep.
So your VTI is calculated based off of the velocity crossing that point, so it's like back sort of calculated into a distance rather than a.
Correct. So it's VTI stands for velocity time integral. So if you remember from calc, if you remember, you go from distance to velocity to acceleration when you take derivatives.
Mhm.
And then when you take the integral, you work backwards.
Mhm.
So your acceleration becomes a velocity. If you integrate your velocity, it becomes a distance.
Oh. Okay.
So that's what VTI stands for.
We're took calc, and we're just memorizing.
You would have had to take in calc.
I didn't pre-calc, and I still got here somehow.
Goodness. So the computer does that for you, but that's why, but that's the area. So that's, so it takes the area under the curve, it integrates it, and you get a distance.
Okay.
All right, so we're gonna fill in the gaps. And if I'm blocking your way, I'm sorry.
No,
So this is our area, so it's the area of a circle, so pi times our radius squared times our LVOT VTI, which is right over here, equals aortic valve area times aortic valve VTI. You do the math, 1.38 centimeters. So does this person have severe AS? No. I think that qualifies them as moderate on the chart. All right. This is great because I know everybody has a phone. Based on the information below, calculate the patient's aortic valve area. And I think I have a couple of these because obviously repetition is beneficial. Uh-oh.
No, yeah.
This is the worst. This is the worst. If you can get through the aortic valve area, and I'm being a little mean because the computer does calculate it for you a lot of times, but
So written question all the way, so you don't really ever look at peak aortic valve gradients, just mean gradient?
per the guidelines,
Okay.
yeah, that's what the guidelines include. Anyone?
I got B.
All right, we got a B. Anyone else?
B.
Got two B's. All right, we'll go through it. So B is the answer. So again, your LVOT VTI, your VTI area or your LVOT area, same thing on this side. So LVOT VTI is 18, and then it's pi radius squared. So you always measure the diameter. You always have to remember to have it. And 2 is about the average LVOT diameter. And that equals 80, so that's your aortic VTI times your valve area. So you just shuffle math, and you get 0.7. This is the worst part through the whole thing. And again, actually, the computer will calculate this if you know how to properly label all of your measurements. So if you're just taking measurements, but you're not labeling them in the machine will not calculate for you. Okay? So that was aortic valve area. And then that was, so the level ones were peak velocity, mean gradient, aortic valve area. And then if you need some more info, let's say, for example, you just can't get a great LVOT diameter or something like that, or you want more data, you can get what's called the dimensionless index. I think it's also called the velocity ratio and stuff like that. But it's basically another way to think of aortic valve area, but you don't include the LVOT area. So you get let's see. So again, you line up, you get your velocities through here, you get your VTIs, and then you just take a ratio. So you can either do the velocity ratio, so your velocity through the LVOT over your aortic valve velocities or peak velocities, or you can do your VTI. And if you're less than 0.25, it's considered severe. So this is just an easy division thing you can do.
I'm confused as to what the difference between that and gradient is. Oh, I see.
Yep, so it's an easy way to measure that.
So if you're trying to figure it out, and if you have some big full cardiac output or something else going on, it's the way it's loading condition independent.
Oh, I see, yes.
And then another thing you might notice when you're doing continuous wave Doppler, you can get this thing sometimes called a double envelope. You'll notice that when you use continuous wave Doppler, you might have an extra shaded in area and then a more faint area. And that extra shaded in area is actually going to be representative of your blood flow through the LVOT. And then the fainter area is going to be the aortic valve. So this is really useful if someone's like an AFib, for example, and you want to make sure you're kind of getting values that are in the same stroke volume, essentially, for the same like instance of systole. Or if you're just really struggling to see where your aortic valve is, sometimes this can be helpful too, because it's hard to place your pulse wave Doppler gates. And then lastly, we talked about what happens if you have a low EF. So if you have a low EF, your heart may not be able to pump strong enough to actually widely open your aortic valve. So you might get a valve area that looks kind of low, like less than 1, but it's just because your heart's so weak, it's not even pushing the valve leaflets open that much. So there is a protocol, a dobutamine protocol, to look to see if you have actual aortic stenosis or more of that pseudo aortic stenosis. The pseudo portion being, yes, your valve area is less than 1, but it's because your heart's so wimpy, not because there's fixed stenosis of your valve. So basically it's, you just start some dobutamine until you've hit one of these 4 parameters. Either you've maxed out your dobutamine, your heart rate rises, or you're having hemodynamic compromise. So those would all be reasons to stop. But basically what you're doing is you're just letting your heart have some more oomph. And if that happens and your valve area then increases to greater than 1, then you had probably pseudostenosis. If your valve area stays less than 1 though, then you actually have some fixed stenosis. So, and if nothing happens when you add dobutamine, then that's just bad.
Have you ever seen it where you have pseudostenosis, but the valve is actually totally normal, or is it usually like moderate stenosis?
I don't know. We don't see a lot of dobutamine stress.
We're scared.
And it gets really, you can get into a bunch of really there are more difficult scenarios in this, but I didn't deep dive into them. But the guidelines do show more difficult scenarios that you will need to know, but not for this. So, all right. A couple cases here, and then we'll get into AI before I run out of time. All right, so obviously this looks bad. All right, and you throw color on it, and you can see so anytime you see a lot of turbulence past the valve, that keys you in that there's probably some stenosis in the valve. So all this turbulent flow. And then what else does it look like there's here?
System.
Yeah, so probably some regurg too. And then if you remember that really nice aorta that we saw earlier, does this aorta look like that aorta? No. All right, and then this is it in short axis. You can see not pretty. Put some color on it. See a bunch of turbulence. You don't see a huge opening with that turbulence. And then that's going to be your regurg. All right. So looking at those images, which of the following parameters is probably most congruent with those images? You take all your measurements. Which one are you more likely to get with those pictures, do you think?
C.
Whoa, okay, we got a C, we got an A, we got an E. Tiebreakers? All right, we got two E's now, so I'm gonna say that one wins. So, when you're going through these, rheumatic maybe, although the whole thing looked really calcified, not just the tips of it. A mean pressure gradient of 33 is gonna put you in the moderate. A peak velocity of 2 is mild. Do we think that looked like mild stenosis? Aortic valve area of 1.1. Again, that's moderate. And dimensionless index of 0.25. So I think just visually it looked pretty severe. Looking at that picture. A lot of turbulence.
Is there any way? to
Didn't
look
really
at it?
see much opening here, right? There is another, it's a secondary one, but you can do planimetry, which is basically you try to snap a picture of the valve when it's open and then trace it. Terribly inaccurate. So that's why I didn't address it, but
Is there any way to just look at the color Doppler and just be like, oh, that's whatever?
not really. If you see a lot of turbulence post valve though, then you can assume. All right, we're gonna look at this one, then we'll go to AI. Again, you look at this and you're like, I don't even see a valve. There's a big old chunk of calcium. So you see that post turbulence here. You see a little aortic regurg right there. In short axis, there's, I think this is maybe the opening here. All right, we're getting some measurements. So this is going to be your LVOT VTI, your aortic valve VTI, and you can see actually there's a nice double envelope here. All right, we'll do this one and then we'll move on to aortic regurgitation with the last 20 minutes that I have. Oh,
LVOT.
do you need it given the information you've been given? So what do you use the LVOT diameter to calculate?
Well, it's for the,
Your valve area,
yeah,
and then, but why do you need your valve area for LVO, or why do you need your LVOT area?
because it's.
So you can
the big-
calculate,
the Big cylinder becomes the small cylinder.
Okay.
That's the big cylinder.
but what of the cylinder are you calculating? What metric of that cylinder?
The height with the.
So the VTI is the
The
height,
height,
and the area is,
Yeah.
and what do you
Yeah.
get when you multiply those together? What is that?
The area. Or
Sure.
the-
Area
the-
times height is,
Sure.
what's the last
LVOT,
value for your
yeah,
LVO
so-
there? Oh, I know. I know. This is the last calculation. All right, so what do we have? What do we get?
B.
B. All right, so I don't know if you heard it on the phone, but basically, remember what I said is that stroke volume through the LVOT equals stroke volume to the aortic valve. So you don't have the LVOT diameter in this one I didn't give you. But earlier in the TE images, they must have obtained it because we have a stroke volume through the LVOT right here. So actually you don't have to do any of the math to figure this out because you already have that data point. So you can just do 62 equals aortic valve area times aortic valve VTI, and you get that. That one was a little trickier. All right, we're gonna keep going. That was just the dimensionless index. That's just LVOT divided by aortic valve VTI. All right. Case 3, same thing, blah, blah, blah. Here we go. All right. So for aortic regurgitation, kind of like with MR, there's a couple different types. One thing to note is that the structure of the aorta is very important to the ability of the aortic valve to have a good coaptation and prevent against leakiness. So if you have aortic disease, like a giant aneurysm or a big dissection that's pulling apart your aorta a little bit, it might I guess not every dissection results in regurg, but deformity of your aorta is going to cause issues with your aortic valve coapting well. And that's kind of this type 1 A through C. And then D is always the leaflets look okay, but they got a hole in the middle like endocarditis. You can have prolapse just like you can with MR, and then you can have restricted motion also leading to regurg. There's 5 different ways we typically measure AI. They're not leveled like they are in the guidelines for AS. So we'll go through all of these. Some of these will seem familiar to what we learned about with MR. So the first one's going to be your vena contracta. So basically, this is your aorta. You can see it's huge. And you're regurgitating back. And if you measure the neck at the narrowest portion, it's sort of like a surrogate for your regurgitant orifice area. And then the cutoffs are 0.3 to 0.6. So this one measured here is 0.675. So this would be considered severe. So you're just measuring at the narrowest portion. You can also look at how much of the regurgitant lesion, how much of that regurgitant jet, what percentage of space that takes up in the LVOT. So if you imagine you have a line going through here, and you were measuring the percentage of this LVOT that was filled with a regurgitant jet, that can give you some clues on how bad your AI is. So if it's only taking up about 25%, that's mild. If it's taking up greater than 65%, that would be severe. So we just kind of think of it usually as 1/4 versus 2/3. If you have a really eccentric jet, that might not be the best way to measure it. You can take really fancy pictures. So remember how I said, just imagine you have a line going through there. Well, you can do that with M mode. And if you guys get TAPSE on surface echo, that's what you're using is M mode. So it's time on the x-axis versus distance, or position, I should say, on the y-axis. So you can see here is your diastole, and you could see this jet probably takes up, if you did the math, takes up a pretty good chunk of the entire LVOT. So this is just taking basically along this line as time goes on. So this looks like it might be a severe jet. The other thing is you can just look at how intense the regurgitant jet is on continuous wave Doppler. So remember that the density is proportional to the number of red blood cells reflecting the signal. Less dense, less regurgitation. More dense, more regurgitation. Obviously, this is a little bit more qualitative than quantitative. But it's a simple and easy thing you can do. The other thing you can measure is pressure half-time. So pressure half-time is the time it takes to go from peak pressure through the regurgitant hole to half that pressure. So if you have a large hole between 2 chambers, is the pressure going to equalize quickly or slowly? Quickly, right? A big hole, the blood can get between the 2 and equalize. If you have a tiny hole, is it going to take longer or slower for the pressures to equalize? Longer. That's what pressure half-time is. A longer value means it takes longer for the pressures to equalize. So it's going to be less regurgitation because it's a smaller hole. A bigger hole, it's going to equilibrate really quickly. So it's going to be fast. So you can see here, so this is your regurgitant lesion. Again, we're measuring everything in that deep transgastric view. Well, this is a little different view, but that's okay. So this is your regurgitant jet, and you can see you take the slope basically, and the computer will calculate your pressure half-time for you. So anything greater than 500 is going to be mild, right? Because it's taking a long time for that pressure to equilibrate. So it's a small hole. Small holes are good for regurgitant lesions. Bad for stenosis, good for regurgitant. And then if this were a very steep slope like this, that means that pressure equalizes really quickly, which means your regurgitant hole must be pretty big. The other thing you can do is you can interrogate the distal aorta. So you find your aorta in long axis, and what you do basically is flow should be going forward down the aorta during systole, correct? Should flow be going backwards in the aorta at any time point? Probably not, right? What if you have really, really bad regurgitation? Could you see some backward flow in the aorta?
Sure.
You can actually, right? It's going back into the heart. That's what you're looking for.
Or if you have a VA cannula in.
Yeah, if you have a VA cannula, you're all messed up. You ain't getting this. Hopefully you don't have a VA cannula in the ICU with severe AI, or you're gonna be in trouble. So basically, that's what you're seeing here. So you're seeing systole with forward flow, and then you're seeing a jet, and this is flow going towards the probe during diastole. So this shouldn't be here. But if you have really bad regurgitation, you'll see this. So that's called holodiastolic flow reversal in the descending aorta. If you have a little bit of regurg, you might see a little blip and then it goes away.
Pulse wave.
You do
At that
pulse
time,
wave.
You find short axis first, and then go to 90 and then. go
Yep.
pulse in the middle of it.
Exactly. The further distal you can be, the more specific sign this becomes.
Distal.
In the aorta. Yep, you want to be as far as you can in the aorta. All right, and that's it. Those are the 5 things. So we'll ask some questions about this. So quantify the degree of AI just based on this picture. So first of all, what metric are they using here? Pressure halftime, okay? Computer calculates it for you. And I'll tell you the cutoffs are 500 and 200. They won't tell you which one they are. Mild. Right, so the cutoff is 500 for mild, and this is even higher than that. So it takes even longer for pressure to equalize, right? So it's a small hole. And you can kind of tell that too, because this, you see how it gets faded towards the top of this? So if there's a really bad aortic regurgitation jet, this would all be filled in really darkly too. So it kind of makes sense with what you're seeing with the regurgitant waveform.
By normal, did you mean this done?
Yeah.
But that wouldn't be there, right? There would be no recursion.
Exactly. Yeah, I like to have fun choices.
Yeah.
All right. Using your eyeball. Mild. All right. Quantify the degree of AI. This is an eccentric jet. Yeah.
Is that this?
So this is a survey. Go ahead.
Moderate to severe.
No.
Severe.
Something more.
I would say moderate.
But what's the?
Because if you get the VTI, or not the VTI, the vena contracta, it's not going to be that big. But it's something you could interrogate more, right? You could argue.
Pattern that relates to going along the foot in that way.
So with MR, if it's eccentric, it's severe.
If it's wall hugging,
Okay.
right?
Is
If
there
it's
anything
wall
like
hugging and going around.
AI?
Not when I was looking it up in the guidelines. All right, what do we think here? What gets your attention with this view in this case?
The aorta is collapsed.
The aorta is collapsing. No. What do you see? So we're looking at the aortic valve and short axis. How is it opening? What do you think? Bicuspid. Yeah, that's probably what you're seeing when you say. So this is that bicuspid fish mouth here. So what raphi would you say are fused? Ooh, that was a perfect pause.
Right.
Yeah, so probably the left and the right are fused right here. Okay. Oh, I could never do that again. All right. What do we see here? So what problems do we think we're gonna see?
Like central regurgitation.
Okay, so we think we're gonna see regurgitation. So that's when it's opening and then it's closed and we see a DAP. We see flow. So we think there's gonna be some AI. Obviously, we're gonna get more views. So what catches your attention in this view? Anything. Okay, so the leaflets look like they have some stuff on, whether it be calcium or something else. What else catches your eye about this picture? Yeah, so you don't see anything, you don't even see great, like a great sinus and then an ST junction. It's all been effaced. So they've got at a minimum a dilated, I can't remember if this is one of my dissection pictures. It's hard, you'd need more views, but anyways. All right, so we're gonna put some color on it. All right, so there's that AI we were seeing. And actually there looks like there's some color up here too even. See that up there? There might be some infection of the root. That's kind of what a root infection looks like. Uh, so this is when you're looking here with the regurgitant vet jet. Now it is eccentric, so this might not be the greatest mechanism. I gave you measurements here, but just looking at this, the cutoffs are 25% and 2/3. Doesn't look that impressive, does it? No. So we're kind of getting discordant values here. Okay. This is a deep transgastric view, which is kind of fun to see. Right. And this is diastole, and it almost looks like there's flow during all of diastole, doesn't there? All right, so now you have one parameter that says severe. You have one parameter that says mild. You have one parameter that says moderate. What do you want to do?
Yeah. But
E?
moderate.
You can say that because it's
Are they symptomatic?
Oh boy. All right. What do we come to I think we got everything. All right. I picked moderate. You could argue the other ones. But more importantly, fix the valve. And why would you fix the valve? What other thing did we comment on? Aha.
Yeah.
So the root was huge, right? So you're going in there anyways. And then what kind of valve, if you remember, did we say we thought this was? Yeah. So it's not all about the severity of the regurgitation, because there's other things. So sometimes we get to squeak out and we don't have to call it severe just to have it be replaced. All right. Let's see. I think we got enough time. Let me.
That mild to severe AI.
Yep. All right. Let me just look here because I want to do the last one. One more question. I'm going to skip case 4. Let me find case 5. Here we go. This is the last one. All right. It is mitral with the Coanda effect. I think they're I think no, I don't think I think maybe at one point they thought if it traversed the whole anterior leaflet, then it was severe, but I think that's been bunked.
Yeah.
Okay.
Gotta memorize stuff that isn't real.
What do we so again, you put the probe in. Normal or abnormal?
Abnormal.
Abnormal. Okay, we're gonna ignore the LV that's just twitching. And we're gonna look at the aortic valve. What looks abnormal about that valve?
Relapsing back.
It's like the wrong way.
Okay, and what leaflet looks like the big problem leaflet right now? The right. So that bottom one's always the right. And remember, this is your RV, and you're always right when you say this one's right. Okay. So we're gonna put some color on it. Holy buckets. All right. So what do we think we see here besides a lot of turbulence? Okay, so wide open AI, we're gonna ignore the MR. Do we think there's turbulence beyond the valve too? Maybe, right? All right, so it sounds like we need to zoom in. So there's that. Do those even look like they're coapting? No. All right, let's throw some color on it. I think the next one has color. There we go. All right. Oh, this just looks terrible, doesn't it? Okay. So let's get some data. Well, first we're gonna look at it in short access, and this actually doesn't look too bad, does it? All right, so you know it's a what type of valve? Is it bileaflet? Try, yeah, so you know it's got 3 leaflets. Good. This just looks like a mess. All right. So you get pressure half time. What do we think?
Very steep.
Very steep. So what is that going along with our thoughts that this might be severe? Yeah, so our value here is 85. Don't be fooled with the AI max value, right? We use AI or we use V max when we're talking about aortic stenosis, not for the regurgitant jet. But we care about this pressure half time here, 85. So the cutoff's 200, so that's well below. This seems like it might be wide open. Okay. We thought we saw turbulence beyond the valve. Assuming that this guy actually had preserved LV function. Do we actually think there's stenosis? Oh, I'm making you calculate your valve area again. I know. But we saw turbulence past the valve. What do we think? And you can see here we used a double envelope. So your values that you want are right here. This is the last question, I promise. You can also cheat like Pinkerton's doing right now. And look at some other things.
Any chance to not have to do that?
Or you can calculate some other things too. Instead of the AVA, I guess. Oh, we got a number that doesn't make sense. Okay.
That's 2.
I got 2.
Okay. So that's what actually you get. So, and your dimensionless index is 0.5, which is obviously there's no stenosis. Pinkerton, what were you doing to cheat?
Just the mean gradient.
Yeah, she was just looking at the Vmax, right? So she was just looking at aortic valve Vmax, which that's, I think the cutoff were 2. I think it's 2.5, if I remember correctly. And then your mean gradient 10. So based on those two, would you expect there to be any critical AS? No. But if you calculated it out, this is what you get. So everything's, so even though there was that turbulence, it's probably from just like that washing machine effect because that valve's wide open. It's not due to any sort of stenosis. This patient had endocarditis of the mitral, the aortic, and the root. So that was it. Any questions for me?
Is there a jet going into the RV?
I don't know. I don't remember seeing that. Did you see one?
I was just. Or is this just? Is this just?
I just think that's,
and
I
this
think that's
is
just eating
us?
away at the root.
Okay,
Yeah,
and this isn't,
yeah. I don't think there was actually a communication.
that's.
I don't think there was on this. I didn't.
Because here, but your point is this is just